Hi, good day. This is Dr. Mitch Schultz, and I want to show you a technique for Durysta Trap and Hold during cataract surgery. So this is a patient that I previously had placed a Durysta in preparation for cataract surgery to quiet the eye down. And as you can see superiorly here, the Durysta is in place. I actually use a dispersive viscoelastic to keep the Durysta away from where I'm operating so that I don't take a chance of actually having it come out of the incision during surgery. I think the key here is that using a dispersive viscoelastic helps to keep the Durysta in place. And as you'll see momentarily when we start the phacoemulsification, um, by using a dispersive viscoelastic, as we start to phaco, the viscoelastic that's being removed fractionates and still keeps that Durysta implant in place as long as we don't remove the viscoelastic anywhere near the Durysta implant. So I'm carefully breaking up the cataract here, and as you'll see, I try to maintain myself in an endocapsular position so that I can leave the viscoelastic protecting the Durysta up against the cornea while I'm phacoing. I'm actually very careful here to remove pieces, and again, staying away from the Durysta implant. And as I've removed some of the nuclear fragments, I then come back and actually place more viscoelastic to protect the Durysta implant as I continue to phaco. So in a second, you'll see that phacoemulsification will be completed, and the Durysta implant is still in place. Again, unlike normal cases where I might just go ahead and do irrigation aspiration, I'm going to again now sandwich the Durysta away from where I'm going to be doing irrigation aspiration. So we push it into the angle, and now we can proceed with irrigation aspiration just as we normally would. I really do like this silicone capsule guard INA because it's very protective of the capsule, and I can be fairly aggressive with polishing. Also, I can see the port really well, and I can avoid capturing the Durysta implant while I'm performing my INA. So now, once we've completed irrigation aspiration, I'm going to go ahead and again refill the eye with viscoelastic, and then I like to perform some polishing. I think polishing is very important when we do cataract surgery. I really like to leave the eye with as little lens epithelial cells as possible to really reduce the chance of having capsular fibrosis. Certainly in our glaucoma patients, we're concerned about inflammation, and so everything we can do to reduce postoperative inflammation I think is essential, and removing lens epithelial cells is just a component of that. So as you can see here, I'm using a Singer capsule polishing system to remove residual lens epithelial cells. We then carefully implant the lens. And again, I'm extremely cautious to avoid removing the implant. Again, I've stuck with a cohesive viscoelastic here just to be sure that I don't remove the Durysta implant. Now once we're done, as you can see, it's starting to migrate. We're going to fill again with another cohesive viscoelastic, and now I'm actually using AmVis Plus. Because I'm going to be doing visco dilation and canaloplasty using the OMNI device, I've actually pushed the Durysta superiorly out of the way of where I'm going to be inserting the OMNI device. So I've gone through a superior incision and cannulated the inferior 180 degrees, and now I'm going through my inferior incision, and I'm going to cannulate the superior 180 degrees with the OMNI device. Now once we've completed the viscodilation, I'm actually going to perform iStent Inject in this case. So with iStent Inject, I like to do the inferior stent first. We place that stent as a trabecular bypass carefully. Sometimes we don't get it on the first try, so it takes a second try. I do like to reposition the scope for the second stent. So you'll see I move over here, and then I come to the superior aspect. And I, again, want to visualize well and go ahead and implant the second stent. Now, the key here is avoiding removing we're going to remove all the viscoelastic now, so we want to protect that Durysta implant. So I actually put a second instrument in, knowing that the Durysta implant is going to eventually come back down. So as you can see, it's very close to my paracentesis port, and I'm protecting it with that second instrument so that it doesn't go anywhere near the INA. Finally, once we remove our instruments, we just do a little hydration of the wound and push the Durysta implant out of the way. And that's the end of the case. Thank you.